requires us patients' rights and treat them with courtesy and dignity. While broad, this establishes our duty to uphold patient welfare and autonomy. The PAO implementing rules and guidelines are more explicit. So, Rule 3, Section 6 states that the IMD shall preserve the confidentiality of patient information and may disclose it only when authorized by the patient or permitted by law. In other words, confidentiality is the default, disclosure is the exception. For those working in government institutions, RA 6713 adds an administrative obligation. The disclosure or misuse of confidential information obtained through one's position may result in disciplinary sanctions, including suspension, fines, or removal from service. So, throughout the cases that we will discuss, keep these in mind: the PAO Code of Professional Conduct, the PAO Implementing Rules and Guidelines, and RA 6713. So these provide the ethical and legal framework for our decisions regarding confidentiality. So looking at our first case, so we have Mr. Santos, who's a 58-year-old patient, presenting to a busy government eye clinic with a painful red eye. So the clinic is crowded and the examination area is separated from the waiting area only by a curtain that is often left open. During the slit lamp examination, the resident notes findings suggestive of herpetic keratitis. Without ensuring privacy, he asks loudly, "Sir, are you HIV positive?" And several patients in the waiting area overhear the conversation. Mr. Santos appears embarrassed and later tells the nurse that he felt humiliated. He does not return for follow-up. Several weeks later, he presents again with a corneal perforation. The herpetic keratitis that could have been treated earlier had progressed because he disengaged from care. So this case highlights how a breach of confidentiality can lead to real patient harm. The problem was not the clinical question itself. The problem was how and where it was asked. The sequence is straightforward. There was inadequate privacy, disclosure of sensitive information, loss of trust, patient being lost to follow-up, and a preventable complication. So when we think about harm, we often think about surgical errors or misdiagnoses. This case reminds us that harm can also result from the way we communicate with our patients. So before we move to the formal analysis, let's discuss the case first. So we consider two questions. First, was Mr. Santos' confidentiality compromised? The resident may have been asking a clinically relevant question, but does that justify asking it loudly in a semi-public space where other patients could hear? So, was Mr. Santos' embarrassment and loss of trust a foreseeable consequence of how the conversation was conducted? Second, who bears responsibility for the outcome, the corneal perforation? Is it the question, the department that failed to train residents regarding the handling of sensitive information, or the institution that provided inadequate privacy and lack regarding confidentiality? So this case reminds us that breaches of confidentiality are often not the result of bad intentions. More commonly, they arise from routine practices, the environmental limitations, and systems that fail to prioritize patients' privacy. So as we discussed, we think about where responsibility lies and what could have been done differently to protect the patient's dignity while still providing appropriate care.
So, so moving on to the analysis of the case, let's revisit the two questions we discussed and analyze them using the relevant ethical and professional standards. First, did the resident violate Mr. Santos' confidentiality, and was the resulting distress foreseeable? So the answer is yes. The PAO Code of Professional Conduct requires IMDs to respect patients' rights and treat them with courtesy and dignity at all times. Asking a sensitive question loudly is in an environment where others can hear, uh, falls short of the standard regardless of intent. The PAO implementing rules and guidelines are even more explicit. Rule 3, Section 6 states that an IMD must preserve the confidentiality of patient information and should not disclose it to third parties without authorization or legal basis. In this case, other patients within earshot effectively became unintended third parties. The patient's embarrassment and loss of trust were also foreseeable. A reasonable clinician should recognize that discussing a patient's possible HIV status in a public setting may cause distress and discourage future care. Second, so who is responsible? The resident bears responsibility for how the conversation was conducted. Rule 3, Section 1 states that the IMD must always place the patient's interests first. including protecting the patient's privacy and dignity. However, responsibility does not end with the individual clinician. Institutions and departments also have obligations. If examination areas provide inadequate privacy, if residents receive little training on handling sensitive information, or if confidentiality policies are poorly enforced, then system level failures contribute to the breach. The lesson is that solutions must occur at both levels. At the individual level, simple measures can prevent harm, ensure privacy before discussing sensitive topics, lower your voice, and choose language carefully. For example, asking about conditions that affect the immune system may achieve the same clinical objective while minimizing stigma. At the institutional level, departments should advocate for consultation spaces, clear confidentiality policies, and training that emphasizes respectful communication. Protecting patient privacy should not depend solely on the discretion of individual clinicians. So the key takeaway is that confidentiality is not just a personal responsibility. It is a shared responsibility between the clinician, the department, and the institution.
Yeah.
Yes, we agree that it's a shared responsibility between the resident, the department, and the institution. No? Now, I'd like to ask you, do you think there was any beneficence what was the resident thinking of when the resident was asking the patient if he had an HIV, if he was HIV positive? What was his intention?
Uh, Siguro, Doc, his intent, sorry.
Endoscopy unit, procedural room for second floor tower 2, medicine response team. Endoscopy unit, procedural room for second floor tower 2, medicine response team. Endoscopy unit, procedural room for second floor tower 2, medicine response team. Endoscopy unit, procedural room for second floor tower 2, medicine response team. Endoscopy unit, procedural room for second floor tower 2.
Okay. Sige. Okay, John.
So answering that,
Yeah.
ako naman.
Can you answer?
I think beneficence in that sense lies in the clinician trying to elicit history from the patient that would later on lead to a more accurate diagnosis for the patient, and in that sense, a more appropriate plan of care moving forward. That's where the beneficence lies there.
Yes, you're correct there, Jed. The patient, I agree that the resident was thinking in terms of other ocular pathologies that might involve HIV. But then again, it was his manner, the behavior of the resident, and at the same time, the environment, That's where, even if beneficence was the aim, in this case, there was non-maleficence that happened because of the psychological harm. Okay. Are there cases that you might know where you may breach the confidentiality? Can you give me examples of why it may be possible ethically?
Actually, Doc, yung next case,
Sa next case ka
it
na.
will tackle that.
Sige.
But
We can,
ano po,
Yung
may
clinic.
naisip ko ba?
no, HIV related.
HIV related, Doc. In terms, technically, Doc, when we have HIV positive patients, when a patient needs to do a procedure, kunyari, surgery, you have to inform the surgeon that the patient is HIV that the patient has HIV for his for the surgeon's safety. Since when dealing with HIV positive patients, especially in the ORs, extra care is needed para hindi mahawa, Doc.
Yes.
So
Okay.
I think that's one
Yeah.
example.
Yeah, there are exceptions naman, di ba?
Yes, Doc.
Yeah. So it's not absolute in this case. Okay. Any other comments from the other residents? You want to add anything to this case? But yes, we agree that the breach was foreseeable and preventable, no? In this case, sometimes confidentiality is very important in daily practice because, as you can see, because of the loss of trust, and trust is very important to the doctor-patient relationship, there was no follow-up. no? That it led to that. No follow-up, there was corneal perforation, and then, it did more harm to the patient. Yeah. Okay. Maybe also I would like to adjust this. It doesn't mean kasi private, public hospital versus private, you should still give the patient the same dignity, the same care you would a private patient. But I know it's very common, especially when we talk to our patients post-op, after surgery, in the operating room. You don't mean to disclose, but while talking to the patient, there could be other patients waiting for their cases, diba? So they will really hear something. So we have to be very careful when it comes to sensitive
The
topics. No?
Communicate.
Yes. Okay. Okay. Sige, you can go
Okay.
on.
Moving on to our next case. Okay.
Sige. Yes,
Dr. Valero.
Dr. Valero.
Hindi, sige. Later na lang siguro after the cases na lang.
Okay, sige.
Sige, follow. So, moving on to the second case. So, unlike the first scenario, this issue is not an obvious breach of confidentiality. Instead, it involves a conflict between several legitimate obligations. So, we have Mr. De La Cruz, who is a 45-year-old jeepney driver who has been diagnosed with primary open-angle glaucoma. So, visual field testing shows significant bilateral superior arcuate defects, raising concerns about his ability to safely operate a public utility vehicle. So he tells the doctor that driving is his family's only source of income and asks her to certify that his vision is adequate so he can keep his license. And at the same time, his insurance company sends a medical inquiry form requesting information about his ophthalmic condition as part of policy renewal. So the doctor now faces two decisions. First, what should she document in the medical record? And any certification she provides. Second, what information, if any, should be disclosed to third parties? So several interests are competing at once. There's the patient's livelihood and financial security, his right to confidentiality. However, on the other hand, we have the safety of the passengers and the public also, the physician's duty to provide truthful medical information, and the physician's professional integrity. Unlike our first case, there is no simple solution, and any decision may have significant consequences for the patient, the public, or the physician. This is where ethical decision making becomes challenging. So not because the right principles are unclear, but because multiple principles point in different directions at the same time. So let's again discuss the case. So we consider two questions. First, does the doctor have an ethical obligation to disclose Mr. De La Cruz's visual field loss to the LTO or his employer, even without his consent? On one hand, the physicians have a duty to maintain patient confidentiality. On the other, there may be concerns about the safety of passengers, pedestrians, and other road users if a driver has a condition that significantly impairs visual function. Where should the balance be drawn between patient confidentiality and the protection of others from foreseeable harm? And second, can Dr. Aquino describe Mr. De La Cruz's vision as adequate on an insurance or licensing form if the clinical findings suggest otherwise? Consider what the form is asking her to certify and what obligations physicians have to provide truthful and accurate information in official documents. Is loyalty to the patient ever a justification for omitting, minimizing, or misrepresenting medical findings? And from these, remember that this case involves competing duties, protecting the patient's interests, maintaining confidentiality, ensuring public safety, and preserving professional integrity. All of these are important values. So the challenge lies in determining how they should be balanced in the situation that we have. So as for that analysis,
So, moving on to the analysis. So, let's now return to the two questions and analyze them using the relevant ethical and professional standards. So, first, does Dr. Aquino have an obligation to disclose Mr. De La Cruz's visual field loss to the LTO or his employer without his consent? As a general rule, confidentiality remains the default. Physicians should not disclose patient information without authorization unless there is a compelling ethical or legal basis to do so. However, we should understand that confidentiality is not absolute. When a patient's condition creates a serious and foreseeable risk to identifiable third parties, duty to prevent harm may justify disclosure. In this case, significant visual field loss in a public utility driver raises legitimate concerns about the safety of passengers, pedestrians, and other road users. That said, disclosure should not be the first step. The preferred approach is to counsel the patient thoroughly, explain the risks, discuss the implications for driving, and document those discussions carefully. If disclosure becomes necessary, it should be done through the least intrusive and most appropriate channel available, ideally after informing the patient. Second, can Dr. Aquino describe Mr. De La Cruz's vision as adequate on the insurance form despite the documenting findings? So the answer is, of course, no. Physicians have an obligation to provide truthful, accurate, and complete medical information in certifications, reports, and official documents. If visual field testing demonstrates significant bilateral defects, describing the patient's vision as adequate would be inaccurate and misleading. While the patient's financial circumstances may evoke sympathy, they do not justify falsifying or misinterpreting clinical findings. Professional responsibility requires that documentation reflect the actual medical assessment. For physicians in government institutions, the consequences may extend beyond professional ethics. Deliberately providing false information in official documents may expose the physician to administrative, civil, or legal consequences. So, the practical approach for this case is straightforward. Document findings accurately, counsel the patient honestly and compassionately, explore available support or alternatives, and if a serious risk to public safety remains despite counseling, consider whether disclosure through the appropriate channel is ethically or legally justified. So this case reminds us that our duty is not only to advocate for our patients, but also to maintain honesty, professional integrity, and concern for the safety of others who may be affected by our decisions.
Yeah, very good, these cases. No? I'd like to hear from any of the residents. How would you approach this case? Sure. Sige lang.
Okay. So,
Kulang.
personally, I think I would agree that although we do understand the patient and his source of livelihood, we also have to think about the other people that will be involved, depending on what we put in on paper as physicians. So even if the patient would ask and explain to us like his concerns in terms of his livelihood, we also have to be responsible not only for our patient but also the people that may be affected by this. So I think I would agree that it's still not right to falsify any documents, especially legal ones, in terms of cases like this.
Okay, yeah, very good. Maybe in this case, yeah, you might say there's personal harm to the patient, but you just weigh it out, which weighs more, harm to the public or the patient. It might help us decide more. And can I divert a little? I'd like to ask about falsification of documents. What about those that ask for PWD? PWD but don't need it. How would you approach it? Just it's the opposite naman. Would you want to comment on that?
I think it's
Sige,
a lot easier now. There's a standardized form that we have to fill out that checks the patient is qualified. So I think it's not an ethical thing anymore. It's more of a legal concern if you falsify the VA of the patient to make the patient qualified. But then we explain na lang thoroughly na what the indications are if the patient qualifies. But if the patient insists on getting a certificate, then we do give the certificate which contains all the facts about the patient's VA, whether the condition is reversible or not. And then it will be up to the governing body if they will give the PW.
All right, thank you. Okay, so going back to the case, Would you like to make a comment, Steve? Case 2? Nothing. Okay, sige, sige. All right, we can go to the third case.
Okay. So moving moving to our third case. So our third case moves from the clinic to social media naman, where many physicians assume their usual rules of confidentiality are somehow less strict. They are not. Dr. Reyes, a vitreoretinal fellow, performs a complex repair on a patient with a rare adult presentation of a certain retinal disease. And during surgery, she captures excellent intraoperative images that would be valuable for teaching. She later posts these images in the professional of the Facebook group. She removes the patient's name and any visible identifiers and believes that the case has been adequately de-identified. However, her caption includes several details. The patient is a 32-year-old male, has diabetes, was referred from a rural municipality in Leyte, and underwent surgery at the hospital she tags in the post. A colleague in the group recognizes the patient. He is a local government employee in a small community, and his diabetes diagnosis was not widely known. The patient later learns that the details of his case were shared online beyond the clinical team. So this case illustrates an important misconception about de-identification. Protecting confidentiality involves more than removing a patient's name. The problem is not any single detail. It is the combination of details such as age, sex diagnosis, geographic location, referral source, and the hospital affiliation, which may seem harmless on their own. Together, they can make a patient identifiable, especially in a small community or when the condition itself is uncommon. In the digital age, confidentiality risks often arise not from the deliberate disclosure, but from the mistaken belief that removing a name is enough. True de-identification requires us to consider whether the information taken as a whole could reasonably allow someone to identify the patient. So again, we consider two questions. So first, was the patient's anonymity truly protected? Dr. Reyes removed the patient's name, but anonymity requires more than deleting obvious identifiers. In a small communities, details such as age, sex, diagnosis, place of referral, and hospital affiliation may be enough for someone to identify the patient. If re-identification was reasonably foreseeable, can we still consider the case adequately de-identified? Think about how information functions in closely connected communities and online professional networks, where a few seemingly harmless details can quickly point to a specific individual. Second, what should Dr. Reyes have done before sharing the images, and what should she do now that the disclosure has already occurred? Should explicit patient consent have been obtained before posting the case? Would a different venue for teaching or discussion have been more appropriate? How much information was actually necessary to achieve the educational purpose of the post? And now that the patient has been identified, what responsibilities does Dr. Reyes now have? Is deleting the post enough? Should the patient be informed? Should the institution be notified? Are there additional steps needed to address the breach and prevent similar incidents to happen in the future? And yeah, so with that, we proceed to the analysis.
So for the analysis, so first let's return to our two questions. And so first, was the patient's anonymity truly protected? So the answer is no. Removing a patient's name is not the same as adequately de-identifying a case. Rule 3, Section 6 of the PAO implementing rules requires IMDs to preserve patient confidentiality and not disclose patient information to third parties without authorization. Although Dr. Reyes removed the patient's name, she shared multiple identifying details: the patient's age, sex, diagnosis, geographic origin, and hospital affiliation. Individually, as said by Jed, these details may appear harmless, but together, they made the patient reasonably identifiable, particularly within a small community and a professional network familiar with local patients and referral patterns. So the fact that another physician was able to recognize the patient demonstrates that the risk of re-identification was not merely theoretical, it was foreseeable. Second, what should Dr. Reyes have done before posting the case, and what should she do now? So before sharing, she should have obtained informed consent, specifically for educational or public presentation of the case. Consent for surgery is not consent for publication, teaching materials, conference presentations, or social media posts. These are separate uses of patient information and require separate authorization. Educational value alone does not eliminate the obligation to obtain consent or protect confidentiality. Professional forums and social media platforms remain third-party spaces regardless of whether their members are healthcare professionals. So now that the breach has occurred, the appropriate response is to remove the post promptly, report the incident through proper institutional channels, document what occurred, and communicate with the patient honestly and professionally. The focus should be on acknowledging the breach, limiting further dissemination, and taking steps to prevent recurrence. The broader lesson is simple. The identification requires more than removing a name. We must consider whether the information, taken as a whole, could reasonably allow someone to identify the patient. And perhaps most importantly, a platform being described as professional does not make it private. The ethical obligations of confidentiality apply online just as fully as they do inside the clinic or operating room.
Okay, yeah, this type of case teaches us all a lesson, especially on justice. When you have cases which are very rare, it's exciting to share it, no? Because it's rare, no? But then again, you have to be more vigilant with cases like this because being rare, it's easier to identify the patient, no? I'd like to hear from Rich. Any comments?
I guess in addition to patient identifiers you're usually familiar with, the mere fact that the patient has a diagnosis is already an identifiable factor to them. Whether it's a rare diagnosis or whether they come from a very specific community. So any point of their consultation is a point that is worth protecting with confidentiality because any part of that could be recognized, any part of that could be detrimental to the patient if it were wrongfully disclosed.
Okay, thank you for sharing. You'd like to make a comment?
So for
Yes.
this case, no, again, confidentiality is very important. So, first, we have to establish whether the confidentiality was or informed consent was gathered from the patient, rightfully, and if the patient did give consent to share, the information regarding his medical details. So, granting that, if ever that it was disclosed unwillingly, so this is a violation against the patient's rights.
Yeah. Thank you. Thank you for your comments. Barbs, can you share anything on any of the cases that you'd like to react on?
I think everything has been said.
Okay, sige. Yes, you, Dr. Sherman, you wanted to make a comment a while ago. Okay.
Yes. Are we done with all the cases ba?
Yes, yeah, the
Okay.
three.
All right. So regarding the first case, no, I think it's quite important for us to remember that there is a certain stigma for communicable diseases in the Philippines, whether it be sexually transmitted or not. No, even TB carries its own stigma. You will listen. You will hear patients saying, when you ask them, may TB ho ba kayo? Wala. They will deny TB. But if you ask them, are you taking medications? They'll say, I'm taking vitamins for my lungs, no, which is one therapy. No, so that's very. I don't know now, but it used to be very very prevalent before. No, or they won't say it's TB. They'll say mahina ang baga, no, or they'll say vitamins for the lungs, no. And then herpes, syphilis, it's very difficult to get that in the history because hindi rin forthcoming ang mga pasyente because there's such a big stigma, no? there is a very famous ophthalmologist, an external disease specialist, who's very, very blunt about asking for sexually transmitted disease. I think the older consultants know that, no? External disease specialist siya, no? So very, very blunt ang pagtanong niya, which will not fly at this day and age, no? They would, parang yung tanong niya is for a sexual, basta very, very crass yung pagkatanong, no? At this day and age, that is not acceptable anymore, no? So you have to be very culturally sensitive when you ask patients, no? Tanggalin mo na yung issue ng privacy, no? Tanggalin mo na yung issue ng privacy. That is a logistical issue, no? That dapat alam nyo yun, no? If the space is too small, it's too exposed, you bring the patient somewhere else if you have sensitive questions to ask. But the way to ask it is also an issue, no? A lot of patients are not forthcoming with information, especially if you approach it with, parang obvious na kayo mismo ay parang may stigma din kayo dun sa disease, no? So, how I do it in my practice is that I do it very casually and nonchalantly, especially ko HIV. I see a lot of patients for screening for HIV, retinopathy, or CMV retinitis. They come to you knowing, or minsan kada-diagnose lang nila ng HIV, no? So medyo hindi pa nila matanggap, hindi pa nila ma-say out loud that they have HIV. So what I do is una, I ask them if it's obviously an HIV, I'll ask, kailan ka na-diagnose, no? When were you diagnosed? What is your current CD4 count, no? What is your current cell count? Sometimes they understand that already, and you don't have to say the word HIV, okay? So you ask peripheral questions, no? And then for TB, again, you can ask peripheral questions, o may binigay bang mga gamot para sa baga. You don't have to say the TB out loud, no? And then indirect ang pagtanong. So medyo culturally sensitive kayo dapat when you ask it, no? So that's one tip that I have for you, no? Even if it's in a private place, sometimes they will not volunteer information, mahihiya sila, and sometimes they will not come back. Okay, so just be careful with that. No? There are ways to say, and there are ways to ask. Two, for the issue of what do you call this? Protection ng healthcare team for patients with HIV, Hep, di ba? Hep C, etc. No? That is why universal precautions are there. No? Para kahit hindi mo alam, dapat nag-iingat ka. So it is the reason why you do not recap needles. It is the reason why you glove up. It's the reason why, you don't share needles or medications, no? The universal precautions, no? Kasi nga, you are protecting the healthcare team, even if you do not know what the patient has. So there is a reason for that. It's not just to make your life more difficult. Is it more helpful if we know what the disease status of the patient is? Of course, it is, no? Mostly pag nagkaroon ng accidental pinpricks, no? But even if you do not have the information, you should all behave as if pwedeng mangyari. Okay, so that's why universal precautions are there. Okay, so that's my comment for the first case. No? For the second case, no. I agree yung parang sinabi, I don't know who said it, no. You should not, give a false certification. That is not just a moral and ethical issue, that is a legal issue. So hindi ka pwede nun because your license is at stake, no. It becomes difficult yung mga ganyan na ako lang po yung nagtatrabaho, etc., etc. What I try to do in my experience is that you communicate about the potential complications of certifying, no? I have a lot of patients who ask for PWD, no, mga ganyan. Sabihin ko, sige, pag hindi kayo, you don't satisfy the criteria for PWD, and you think about it, if you're PWD, it might have complications in your work, especially if your work requires vision, no? So Say, PWD is a public document. It is a, you show your card, it will show you it's a visual disability. How will you be able to work if you have visual disability? More often than not, they will acquiesce, no? Sometimes they're really mapilit. At that point, I say, hindi pwede po sa, ako naman po ang magkakaroon ng problema, no? So, and you leave it at that. Minsan it's difficult kasi nakakaawa talaga, no? You want to help, you want to, but I think that at the very, very least, you refuse, no? I wouldn't go as far as saying, making a certification that he's legally blind so he cannot drive, no? I don't know what the others think, but at the very least, you should refuse to give a positive certification on that, no? Kasi may consequences nga yun. At saka, it's also a legal issue, no? At if they insist, I give a certification, like I think what Mike said, no, stating all of the facts. They can do with it as they wish. Okay, so hindi ka lang pwede mag-lie. Just give the certification. Kung sumama ang loob nila, sorry na lang, no. But you cannot be untruthful about that. And third, no, yung sa social media, no, I think that case that you showed, actually yun nga, educational value pa yun, no? A lot of times, nagkakaroon tayo ng, especially residents, no? They post milestone surgeries, landmark surgeries. My first cataract surgery, my first vitrectomy, my 200th vitrectomy, or whatever it is. No? So, may ganon. No? So, wala na nga educational value yun. You're putting yourself at risk pa. So, just be very careful about that. No? I know you guys, of course, it's like it's human nature for us to parang, ano mo naman ng konti yung mga milestones mo, no? I-press release mo naman ng konti yung milestones. But just be careful with the data that you post, no? It's not according to the PAO social media guidelines, it is not disallowed, no? But you have to make sure that de-identify talaga yung pasyente. And yun nga, as you've said, just taking out the name is not enough, no? Especially may mga kaso na like CMV retinitis na nilagyan mo ano. So may mga ganon, 'di ba? So mas double pa yung stigma nun. Pinost mo na yung pasyente, pinost mo pa yung communicable disease. So it's double double whammy yan, no? So and then lastly, the consent of Makati Med, consent of procedure, it says, I don't know if you are aware of the consent form of Makati Med, no? I'm not sure what version this is. There is an item there that says, ano ba dito? Wala na pala, tinanggal na pala. We have been talking about it in terms of the consent of the patient for photos, no? Syempre, yung mga FA, meron talagang photos yan. But yung mga surgery nyo, walang consent for video yan. If you think about it, if you look at the consent in surgery, I don't think there is a consent for videoing. Let's review that na lang. I'm not sure, no? Ang alam ko may consent for photography and videos are the procedures in the eye center. No, in the OR, I'm not so sure. No, so just be careful when you are posting because that might prove to be a problem. Okay, that's it for me. Thank you very much.
Thanks so much, Sherman, for sharing all of that, no? But going back to what you mentioned about a consent for videos, do you think it's necessary that we add that to the consent form?
Yes. In fact, I think, Stephen, di ba, in the last meeting with the chiefs and the department chairs with Deemer, that was what was being talked about. I'm just not sure. I'm trying to look for the consent form. Siguro, you can look at the consent form of the OR later, no? para to see if videoing is there, no? Kasi hindi lahat ng surgery may video capabilities eh. Tayo lang, ortho, no? So hindi ko alam if it's in the general surgical consent form. I have to look into that. So if it's not there, yes, we have already recommended that it should be there, no? Because nga we do record without the consent of the patient, no? Especially the residents, no? Di ba you record it for training purposes. What is included in the consent and the general consent is that I understand that Makati Med is a teaching hospital and that residents and interns may participate in the care of patients, no? But it doesn't involve videoing. I'm not sure, no? So I'll have to check on this, no? So yun lang. Maybe you can take a look at it later.
There's a
May
separate
form.
consent form.
May separate
for
consent form for
clinical
the photography.
Yeah.
For photography, oh. Do we have the patient sign that?
Not for all patients though.
May iba
The
daw.
OR?
May iba, but sa HSP parang hindi.
Ano, maybe it's good for all.
You might have to, no?
It's-
Especially for HSP because we do record your cases. No, for private, hindi masyadong nagre-record, pero for those who record, we'll look into that, no, and see if we can consolidate that already into the tawag dito, in the general consent form. Maybe Leo, if in the next OR meeting, let's discuss that na lang. Kasi affected tayo dito. Thank you.
Thank you.
O yung mga fundus photo, ay mga photo nyo sa tawag dito sa OPD, kinukuha
Viber.
yung picture, di
Viber.
ba? Tsaka Viber, no? So, di ba we have a slit lamp photo in the OPD? I don't know if that is covered by our OPD consent. So, I think it's time for us to check that. Okay. So, this is a good topic to discuss kasi marami tayong tinitake for granted. And also because technology has changed. Whereas before, hindi very, very special ang slit lamp photo. You have to send that to the eye center. Iko-consent mo yan because it's a procedure. Now, you do it right and left, no? So the technology has changed, so has evolved, but our consenting has not yet evolved. So yun lang ang ano. So we will look into that. Buti na lang diniscuss nyo to today.
Yeah, thank you. Thank you for that, Sherman. I was also wondering, since you did mention that, then it means all the results of patients which are sent via social media, they're emailed to us.
Hindi. We are covered by, in the eye center, we are covered by the consent, no? That there is photography, it may be transmitted for whatever purpose. Parang radiology yung consent natin dyan eh. So that can be, that is part of the consent. Ang hindi kasama sa, kasi expressly, ano yun eh, requested yung photography, di ba? So you will need to consent for that. Angiography, B-scan, lahat ng may imaging, no? Tawag dito, ano pa ba? OCT, may mga ganon. Lahat ng ini-image natin sa eye center has a consent for image, no? And I think kasama yung pag-transmit. Ang ano lang, ang importante doon, transmission should be what do you call that?
Encrypted.
Encrypted. That's why Viber nga actually hindi pwede. Technically, it should be WhatsApp. Kasi encrypted ang WhatsApp. End-to-end encryption ng WhatsApp.
Viber is also end-to-end encryption.
End-to-end. Ano ba?
Oo.
Naglolo ko lang siya.
Ayan. Kailan Viber is the official messaging app for Makati Med if it did not break down a few months ago.
Yeah,
for
now
some
it's WhatsApp
doctors.
na, di ba?
Yeah, but sabi nila mas encrypted daw ang Viber. Anyway, that's another
Okay.
issue.
But
Yeah.
no one uses WhatsApp too much, no, so in Makati Med. So yun lang. Siguro another related thing I just want to bring up to our residents and even our consultants, our interns, no, everyone, our administrative staff. please do not talk about patients in the hallways and elevators. No, I've heard so many residents and even consultants talking about a patient in the elevator. O, kumusta na si patient, si room ganyan-ganyan? Umihi na ba? Kumusta si room ganyan? Kumusta yung how's the infection? And sometimes may mga comments pa, no? So, be very, very careful what you talk about in the elevator. It may seem harmless to you, but if I'm listening and I know who you're talking about, I've experienced one incident na I knew the patient they were talking about. No, I knew kung sino yung pasyente nila kasi kilala ko yung patient, inadmit for that, and alam ko na yun yung doktor niya. Pinag-uusapan sa elevator. No, so it is a public space. I know that sometimes you endorse on the go, but be careful kung sino nakakarinig. Yun lang.
Yeah, thank you for all the reminders. No, sometimes we don't intend it maliciously.
Yes. Oo.
We take it for granted, but that's when we take it for granted. It might be we might call it a little bit carelessness, but it's something we're so used to na kasi, di ba? You give your post-op or
Correct.
post-op outside, right there in the waiting room, and there are patients naman waiting for their own own patients rin, no? So they can pick up bits and pieces.
May bagong issue pa nga ngayon, parang people are asking, do we have to put the names of the doctors outside the patient's rooms? No? Because, halimbawa, ilagay mo yung pangalan ng infectious disease specialist sa labas ng room ni Dr. Elaine kung na-confine siya, no? People will think, anong infection ni Dr. Elaine? No? Parang ganyan. So, there's even discussion about that, no? But it is a logistical parang for the hospital na kasi kailangan nandun, no? But that's also if you think about it, that's also, 'di ba? Privacy issue din 'yon. So I think we should just be more aware, no? And for our interns, no, for our postgraduate interns, no, simulan yung maaga to be very, very conscious about that. Because if at the start you're not conscious and you think it is okay, that you think this is part of medical hospital life, no, you will not realize that mali siya, no, that there are not necessarily mali, that there are consequences to that, no? So yun lang.
Yeah.
Thank you.
Yeah, thank you for bringing it up. Bernie, yes. Can you unmute? Then we'll call you after Jan. Yes, Bernie.
Sorry. No, I just wanted to share lang since we're talking about here anonymity and then identifiers. If you can actually based on the slightest hints, you can actually put it on ChatGPT or Gemini and come up with several so that's how ano na how advanced the AI is. You can put in like as many like facts about whatever, and then next thing you know, you can find out who that person is. Yun lang.
Thanks for sharing. Yeah. It's not the same anymore. We don't have our privacy. Yes, Jan. Yeah.
I just want to reiterate, no, there's a lot of things that we do which we are not aware of, no, but ang dami nang na-sanctions na mga interns and residents because of breaches in confidentiality. Sometimes you have endorsement papers that are left hanging around sa mga, what do you call that, some nurses station, no? May mga na-sanction na doon, and it's serious. There was also a time when a patient complained because her photo was endorsed to another service, which is actually legit, but they found it very offensive. And if the patient wants to complain to the hospital, they can make that a big issue. So I think we really have to push for consent about that. I also want to make a comment about what Jola said earlier about informing the surgeon that this patient has a particular infectious disease or ano. Actually, we go by, as Dr. Sherman has said, universal precaution. We don't mark the chart as may HIV to or there's being referred for retinitis CMV. So wala talagang mark pati sa OR sasabihin, how do you prepare yourself? You have to double glove, wala ka dapat sabihin daw. So it's either the patient with his consent dun sa IT lang niya or sa ID, infectious disease doctor, or the attending physician. So they're very, very strict with this because ang dami ng mga nag-complain sa ospital. So just be careful na sa OFTA kasi maybe we're just a bit lenient. Tayo pa nga maraming we have a lot of photos, no? We rely on a lot of imaging. So we can get we can get red-handed if we're not careful. Yun lang.
Yeah, thanks for sharing also. Any other comments from the other consultants here? Okay, I guess this topic is really very interesting for all of us and very applicable. Confidentiality is very important. As you can see here, privacy is for the patient, no? Their own personal information and data, but the confidentiality is the doctor. It's the doctor's responsibility, no? And another thing we have to remember, it was emphasized a while ago, truthful documentation. It's very important. We do not compromise that. It's all part of professionalism. So basically, gaining the patient's trust, it's all there. We need that for the doctor-patient relationship. So we just have to be careful because we might be so used to like what we're used to, endorsing or talking about our cases in public places. We have to correct that if we've been so used to it now, no? So maybe it's good to reset. It's very important for all of us, especially now so much litigation, no? So, and whatever's posted, as we know, it's there forever, you can't put it down. So there, I'd like to ask the two presenters. It was a very good presentation. What did you learn from the case, Jed, from this presentation?
Yeah, what I've learned is as beginning residents, as first year residents, it's really important to build on the proper habits moving forward, which I'll carry to when I become to when I establish my own practice already. Since it's been mentioned parang some of these can be we do routinely na akala natin tama, pero hindi pala. So as early as now, it's important that we take in these lessons so that I may bring them forward.
Okay, thank you, Jed. John.
So, siguro, Doc, kunyari ako, for the first case, so yung confidentiality, Doc, it's not just on how, it's not just about what we say, pero important din where and how we say it. Like, so yung sabi nga ni Doc Valero kanina, it's important on how we get the information from yung mga patients nga with diseases na may stigma. Second, that I learned, so may limits din naman, Doc, yung confidentiality. Pero yung limits don't require strong justification, just as we seen sa scenario 2. So kung may strong justification to breach the confidentiality by this, if we need to disclose yung information, siguro we can do it naman, like for this for the the second case.
Yeah, thank you. So maybe just something to think about anytime before you disclose anything, whether on social media or to another colleague. Just always ask yourself if what you're disclosing is really necessary to do. And if ever you do, always find out if you did the proper consent. And then again, consent, I would say documentation talaga, no? Yes, Carmela?
Hi, I just was anyway, thanks for a really nice, interesting conference, nice presentation, and nice moderating, Elaine. However, I have a question about so you mean to say when you have a case presentation, do you have to ask permission from the patient Like whenever we have these cases here in conferences, does the patient have to know that we're going to, do we have to disclose or ask for their permission?
Technically, yes, Carmela.
Do that? Do we do that? I mean, do you
But
guys do that?
ang general consent kasi ng Makati Med is that Makati Med is a teaching hospital, so your case, our interns or residents may be involved in your care and parang kasama yung discussion yata ng kaso mo, no? But yun nga, wala pa ang for the photographs, may consent yon to take photographs. But technically, you really have to ask the patient. Technically, no? We get
Okay.
away with not asking kasi wala pang problema. Pag nagka-problema, patay tayo because we don't ask.
Yeah. Okay, thanks.
I think, Carl, yung sa mga, when we give our case report, it's always parang routine. We just give the age and the sex. I don't know if that's enough to identify the case with the diagnosis, but it's difficult also not to de-identify so much kasi nag-iiba yung, we really need this for teaching eh. So as much as possible, parang meron ng dekahon, 48 male, and then ganyan. Then sometimes for teaching, we can, I don't know, sa bioethics kasi we tweak it a little para hindi, lalo na yung mga celebrity cases. But just the same, no?
You,
Andun pa rin eh, malalaman lang.
you twist the case, you parang fake the
A little, yeah. Kasi if you change it so much, hindi mawawala yung learning value, di ba?
yeah.
But for
Diba?
scientific kasi na cases, you cannot change kasi it has to be truthful to the case. Now, the way to fix that is just really get a consent from the patient that it will be a teaching case, it will be presented, etc., etc. The problem is we don't have an existing consent form for that. I'm not sure. So that's something we have to check also, you know. But technically, you do have to get consent. In other institutions, before you present a case, kailangan may consent yung patient.
What I know that we ask consent for is also from the attending.
Yeah, the attending, pero they're not the ones naman that are,
It's
diba?
not.
You're assuming that the attending has consent,
Uh-huh.
diba? But even the attending may not have the consent to post that picture or to make that picture into a study material, no? So we'll look into this, and so we'll probably need the help of everyone in looking at these consent forms, no? So we'll start with the one in the OR for recording, and we'll also look at the one in OPD, and then maybe we'll ask Deemer to see if there's a consent for presentation of cases for residents and interns. Thank you.
Yes, thank you everyone for attending the conference today. We all learned a lot from it. Do you have any other important messages?
So yeah, so the board exams are this Sunday, no? So send some good thoughts and prayers for Trisha and Ollie, no, and hope they do well in the exams, no. So I think they're prepared naman for it. So hopefully we get the good results. They get the good results that they prepared for. So thank you very much again to the Bioethics Service for another interesting topic. No, I hope that our the staff, no, residents, consultants, interns, have taken some lessons from this. No, it's really awareness that's important. No, you have to be aware of what you're doing. You have to be aware of the possible consequences of what you're doing, and you have to be aware of the governing rules and laws, no, about these things and guidelines, no, PAO, PMA, no, legal, etc., no, so that you can behave and act accordingly, no. again, as I've said, times are changing, no? We didn't used to have text before, we didn't used to have Viber before, so we just call and refer, and at that point, walang trace yun, no? Kasi tinawag mo dun sa consultant mo. But ngayon, you hardly call the consultants, you text everything, no? So there's a record of that, no? And then dati photographs were very difficult to transmit, no? You just have to bring the photograph to the consultant, and or you talk with each other, no? It's a production number. And ngayon, it's so easy that a lot of things fall through the cracks. Because we think it is okay, because it's part of life, no, it's part of our processes na, without stopping to think of the relevant issues and the possible complications. So yun lang, let us be aware, no, let us be curious. Palagi naman sinasabi ko sa bioethics, natin, let's be curious, no, kung ano yung mga implications ng ginagawa natin, so that we get to stop and think. If there's anything that we want you to take away from these bioethics discussions, is that the next time something happens, the next time there's a situation, you stop and you think, no, na napapaisip ka, tama ba ito o mali? Because it's only when you get that pause will you be able to think kung meron bang issue yung ginagawa nyo. Sige, kasi kung tuloy-tuloy and you think it's part of life, it's part of daily usual practice, no, you don't even question it anymore. And then kino-question nyo lang kapag nagka-problema na. So avoid natin magka-problema from the very beginning. All right, so thank you very much, everyone, and we'll see you again in the next conference. Thank you again to the bioethics team, no, and thank you to Jolo and Jed for an excellent presentation, and Elaine for excellent moderating. So thank you very much, everyone. Have a great weekend.
Thank
Thank you, everyone.
Thank you.